Welcome to our video on obesity, metabolic syndrome, and pancreatic neuroendocrine tumors. Here's our overview slide, and we're going to start with obesity. Obesity is defined as a body mass index, or BMI, of 30 or more. It's a multifactorial disorder. It's influenced by both genetic and environmental factors, such as overeating and a sedentary lifestyle. And it's the greatest modifiable risk factor for hypertension, and it actually increases the risk of coronary heart disease, as well as diabetes mellitus and dyslipidemia. Now, treatment is weight loss, which can be achieved by lifestyle modifications, such as dieting and exercise. And if that fails, pharmacotherapy can be initiated. This includes the drug orlistat, which is a pancreatic lipase inhibitor, and that reduces the digestion and absorption of dietary lipids. Another option is combination phentermine and topiramate. Phentermine is a sympathomimetic agent, while topiramate is an anticonvulsant, and it's a nerve pain medication. Now, how these drugs cause weight loss is not actually known, but just know that they're options. And if all that fails, and the patient has morbid obesity with complications such as hypertension, then you can actually go for surgery. Now, bariatric surgery is the most effective treatment, but the idea is that you're trying to help them achieve significant weight loss that's sustained. You want them to keep it off. And bariatric surgery, including gastric bypass surgery, is indicated in patients with severe obesity. So their BMI would be over 40. And of course, in those patients, you would have tried medical therapy first, and they would have complications because of their obesity. And it's actually once you've documented proof that they've tried medical therapy and failed it, that insurance companies will actually pay for bariatric surgery. So it's actually a very enforced prerequisite to start with medical therapy first in these patients. So next, let's discuss metabolic syndrome. Metabolic syndrome is a constellation of several metabolic abnormalities, which together increase the risk of cardiovascular disease. The diagnosis is made when at least 3 of these 5 metabolic abnormalities are present. These include visceral or central obesity, characterized by a waist circumference of 40 inches or more in men and 35 inches or more in women. Hypertension, that is blood pressure above 130/80, a triglyceride level of above 150, low HDL, so less than 40 in men or less than 50 in women, and hyperglycemia, so a fasting blood sugar glucose greater than 100 or more. And notice that the fasting blood sugar level of 100 doesn't meet the requirements of diabetes, but in a lot of these patients, they would meet requirements of diabetes, and it would be much higher, as discussed in the diabetes mellitus lecture. As already mentioned, metabolic syndrome is associated with increased cardiovascular mortality. Insulin resistance is the central abnormality behind this disorder, and it's associated with other common conditions such as PCOS, non-alcoholic fatty liver disease, often called NASH, and acanthosis nigricans, which is hyperpigmentation and thickening of the skin in areas such as the axilla or the neck and the genitals. Also, hyperuricemia, and that can cause uric acid stones. So since a lot of these abnormalities share a common underlying abnormality, many of these patients with metabolic syndrome also have evidence of NASH and elevated uric acid levels. The treatment includes lifestyle modification to improve insulin sensitivity and reduce obesity, as well as blood pressure and improve dyslipidemia. Now, metformin can improve insulin sensitivity and reduce weight, and antihypertensive agents and statins can be used to control blood pressure and lipids, respectively. A 40-year-old female with metabolic syndrome presents to her primary care physician asking for a referral to a bariatric surgeon. What kind of discussion should the physician have next? Okay, so part of the discussion should establish what the patient has already tried. First-line treatment, as you may recall, includes lifestyle changes, and those include changing their diet and increasing physical activity. And graded exercise is important to prevent injury, so you don't want them to go all in, really intense right at the beginning. And with dietary modifications, those should be lasting, so no fad diets are recommended. Okay, so lifestyle changes, first line. Second line is pharmacologic agents. Remember we said orlistat, phentermine, and topiramate. After these interventions have failed and there's morbid obesity, then surgical intervention may be considered. Next, we're going to discuss pancreatic neuroendocrine tumors. Let's begin with insulinoma. It's a beta cell tumor producing insulin. It's usually benign, and in some patients may be a component of multiple endocrine neoplasia type 1, or MEN1. Increased insulin level in these patients manifests as recurrent hypoglycemic episodes, and those would need to fulfill Whipple's triad. So what is Whipple's triad? Well, that includes symptoms of hypoglycemia, such as irritability, blurring of vision, and weakness, and you need to document low blood glucose during those symptoms. So that's 2 so far. You have the symptoms, and you have documented low blood glucose during those symptoms. Third, you need to see a rapid resolution of those symptoms when you administer glucose. So that would be Whipple's triad. To confirm the diagnosis of hyperinsulinemia in these insulinoma patients, a 72-hour fast is done, and that's the most accurate test. To perform this test, a patient has to be well, which means they're not currently in a state of hypoglycemia. And then you make them fast for 72 hours, and at the end of this time period, blood is drawn for glucose, insulin, and C-peptide. In addition to fulfilling Whipple's triad, patients with insulinoma show elevated insulin and C-peptide levels. You may recall from step 1 that C-peptide is secreted with insulin from pancreatic islet cells, and it therefore confirms that the elevated levels of insulin is coming from the patient's own pancreas. Now, since sulfonylurea overdose also stimulates endogenous insulin secretion, similar results will be shown. So they can actually produce high amounts of insulin and C-peptide. So in cases where suspicion of a sulfonylurea overdose is high, then a sulfonylurea urine or serum screen can be done to rule this out. If it's an insulinoma, then obviously there would be a negative sulfonylurea screen. Now, after you've done those labs, a CT or MRI of the abdomen can be done to locate the actual tumor, the actual insulinoma. Treatment of choice is surgical resection. In patients awaiting surgery or those who are not surgical candidates, support with regular carbohydrate consumption is actually recommended because you don't want them to have any more hypoglycemic episodes. Now, octreotide, a somatostatin analog, is also prescribed to inhibit insulin secretion. Again, you're trying to prevent hypoglycemia during that time prior to surgery. So let's discuss gastrinoma. It's a pancreatic or duodenal tumor that produces gastrin. Gastrin is a hormone, and it's normally secreted from duodenal G cells, and that causes proton secretion by the parietal cells, so the acid. So this gastrinoma producing all this gastrin will stimulate those parietal cells to produce more acid. And what does all that acid do? Well, it causes intractable peptic ulcers and damages the mucosa. Now, this recurrent peptic ulcer disease, due to an underlying gastrinoma, is known as Zollinger-Ellison syndrome, and it's usually refractory to over-the-counter antacids and H2 blockers. And that makes sense because those medications wouldn't do anything to stop that gastrinoma from secreting all that gastrin and stimulating the parietal cells. Now, a number of these cases of gastrinoma are actually associated with multiple endocrine neoplasia type 1. Patients present with features of peptic ulcer disease, such as abdominal pain, epigastric tenderness, and they may have occult GI bleeding, as well as nausea and vomiting. In addition, mucosal damage due to excess acid leads to malabsorption, manifesting as diarrhea or even weight loss. Inactivation of pancreatic enzymes by that excess acid also contributes to this malabsorption. And naturally, these patients will have markedly elevated fasting serum gastrin levels. So very intuitive. They've got a gastrinoma, so of course their serum gastrin level is going to be high. And that's even during fasting. And that implies that you don't need food in order to stimulate the gastrin release. It stays high all the time. The secretin stimulation test is the diagnostic test of choice, and that's to confirm the hypergastrinemia. Normally, secretin administration decreases gastrin production. In contrast, patients with gastrinoma will show increase in gastrin level with secretin administration. A CT scan of the abdomen is next done to localize the tumor. So that's something common to both gastrinoma and insulinoma. You do these clinical findings, you do a lab test to see if the serum levels represent what you're expecting, whether it be gastrinoma or insulinoma, and then you do imaging because you're trying to locate that tumor. Treatment is surgical resection of the tumor. High-dose proton pump inhibitors are effective in controlling ulcers and mucosal damage. And many of these tumors are malignant, so they require chemotherapy sometimes, especially if they're metastatic. Now let's go to glucagonoma. This is a glucagon-producing tumor in the pancreas. Glucagon is a catabolic and counter-regulatory hormone. It also causes amino acid oxidation, and so excess amount of it is toxic to a number of tissues. So the skin, for example, and there it will manifest as necrolytic migratory erythema. That's an erythematous painful rash, most commonly affecting the lower limbs or the perineum. Because glucagon causes hyperglycemia, patients may present with new-onset diabetes mellitus, although it's often pretty mild. There may also be weight loss, because it's a catabolic hormone. Other commonly seen features are diarrhea, venous thromboembolism, depression, and psychosis. Here's an image showing the necrolytic migratory erythema, characteristic of glucagonoma. Note the well-demarcated erythematous and blistering rash. Now, the diagnosis is confirmed with markedly elevated glucagon level. Again, that's intuitive because it's a glucagonoma, so it's going to produce lots of glucagon. And labs may show hyperglycemia and a normocytic normochromic anemia. And the hyperglycemia occurs because glucagon stimulates glycogenolysis in the liver. And of course, that would lead to increased glucose output from the liver. Now, the exact mechanism of the normocytic normochromic anemia in glucagonoma is actually unknown. Now, CT scan helps localize the tumor, and at that point, you can treat it with surgery. Again, just like the other pancreatic endocrine tumors we've talked about, you confirm it with labs, and then you image it because you want to go resect it. So VIP-oma is a tumor producing VIP, or vasoactive intestinal peptide. VIP increases intestinal fluid secretion and inhibits gastrin secretion, thereby causing watery diarrhea as well as hypokalemia due to the potassium loss with the diarrhea. Also, achloridria, and that's due to reduced acid production. And that triad is known as WDHA syndrome. Watery diarrhea, WD, hypokalemia for the H, and then achloridria for the A, WDHA syndrome. Workup shows low stool osmotic gap, which indicates it's a secretory diarrhea. Also, the serum will reveal a high VIP level. Then, of course, a CT scan will help you localize the tumor. Supportive treatment includes fluid and electrolyte replacement as needed. And that makes sense because even before you go for surgery, which you, of course, are going to do, then you're going to need to address the achloridria and most likely the hypokalemia. Also, you can give octreotide to reduce the diarrhea. And that makes sense when you think about what octreotide is. It's a somatostatin analog. And somatostatin inhibits or is counter-regulatory to many of these pancreatic enzymes. The last topic in this lecture is somatostatinoma, a somatostatin-producing tumor. Recall from step 1 that somatostatin inhibits secretion of various GI hormones, and reduced secretion of cholecystokinin, CCK, will increase the risk of gallstones because it reduces the frequency of gallbladder emptying. Also, reduced pancreatic hormone secretion causes malabsorption of fat and other nutrients, and if that all stays in the GI tract, especially the fat, then the patient will have steatorrhea. And reduced insulin secretion may manifest as hyperglycemia. And it's important to note that the majority of these tumors, these somatostatinomas, are malignant. So, in addition to surgical resection, most patients need chemotherapy. And the tumor cells have receptors for somatostatin, which inhibits tumor growth and secretion. So, octreotide can be used in these patients for symptomatic treatment. Let's wrap up with a board-style question. A 58-year-old male presents to the emergency department with 3 weeks of abdominal pain. He came in today because he noticed that his stools have become dark-colored, though the consistency is the same. He also reports associated nausea without vomiting. The blood work is pending, but a mass is seen on his CT scan. What lab values are most consistent with this patient's likely pathophysiology? A. Increased insulin and C-peptide. B. Increased insulin, normal C-peptide. C. Increased gastrin. D. Hyperglycemia, normocytic normochromic anemia. E. Hypokalemia, low stool osmotic gap. Or F. Hyperglycemia and decreased cholecystokinin. Okay, so this patient has abdominal pain, discoloration of the stool, nausea, and a mass found on imaging. And the stool color change is likely the result of blood in the GI tract, and that, along with the abdominal pain, suggests peptic ulcers. Increased acid production by parietal cells is one of the causes, and the mass suggests that potential source. So a gastrin-producing tumor, a gastrinoma, would account for this patient's symptoms, which would have increased gastrin on laboratory evaluation, making C the correct answer. Increased gastrin. Now let's discuss why the other answer choices are wrong. A is incorrect because increased insulin and C-peptide is consistent with an insulinoma, which would present with symptoms of hypoglycemia, such as weakness, blurry vision, and irritability. And that's not really what we saw here. Now, B is incorrect because increased insulin without changes in C-peptide is found in abuse of insulin or exogenous insulin, or even just misuse of it. For example, administering too much insulin without enough food intake. And of course, that insulin that's injected doesn't have any C-peptide with it. So you'd have this high insulin and normal C-peptide. And hyperglycemia with a normocytic normochromic anemia would be the laboratory findings that you would see with a glucagonoma. So D is incorrect. Now, glucagon in excess leads to tissue necrosis, presenting as necrotizing migratory erythema. It may also present with new onset diabetes, weight loss, diarrhea, depression, and psychosis. So let's talk about E. Well, a VIP-oma presents with watery diarrhea and a low stool osmotic gap and hypokalemia. And this patient does not have those changes. So E is incorrect. Now F is incorrect because hyperglycemia and decreased cholecystokinin would be found in a patient with somatostatinoma. And a patient with a somatostatinoma would be more likely to present with symptoms of cholecystitis, such as right upper quadrant pain, and of course it would be worse with meals. And we didn't see anything like that with this patient. So again, the correct answer is C, increased gastrin. And that concludes this section.